Hello, today our ground round is by Dr. Hesham Zamel. Dr. Hesham will present the new KDIGO guidelines 2020 about the management of membranous nephropathy. He will discuss the role of the anti-PLAR-A2 antibodies and the use of rituximab in the treatment of the disease. Thank you for watching.
Bismillah ar-Rahman ar-Rahim. Today we will discuss membranous nephropathy, approach to management, and review the recent guidelines, KDIGO guidelines published in June 2020. With you, Dr. Hesham, specialist nephrologist at an hospital. Membranous nephropathy. What about the definition of membranous nephropathy? Membranous nephropathy is an immune complex glomerular disease in which there is immune deposit of IgG and complement in the podocytes on the subepithelial surface of glomerular capillary wall. Podocyte injury results in increased glomerular permeability, which results in proteinuria and nephrotic syndrome. Membranous nephropathy is the commonest cause of idiopathic nephrotic syndrome in non-diabetic adult worldwide. Represents up to 1/3 of biopsy diagnosis. Membranous nephropathy is most common between 30 and 50 years of age, and the incidence of membranous nephropathy increase with increasing the age. It accounts around 40% for adults over 60 years. Membranous nephropathy is a slowly progressive disease and usually seen in Caucasian. Primary membranous nephropathy accounts around 85% of all cases of membranous disease. Secondary causes, there is multiple causes for membranous nephropathy. First cause is autoimmune, like in class 5 lupus nephritis. This is the most common autoimmune. And less common causes of autoimmune disease that can cause membranous nephropathy, like rheumatoid arthritis, IgG4, and ANCA-associated glomerular injury. Infections. Hepatitis B is common cause for membranous nephropathy, and less common hepatitis C, HIV, and syphilis can cause also membranous nephropathy. One of the secondary common causes for membranous nephropathy is malignancy. It's commonly associated with solid tumor like colon, stomach, lung, and prostate, and could be associated with other malignancy but less common like non-Hodgkin lymphoma and melanoma. Drugs that can cause membranous nephropathy, non-steroidal, and less common is D-penicillamine and gold salt. Other causes for secondary membranous nephropathy like sarcoidosis and graft versus host disease can cause membranous nephropathy. The primary pathology involves thickening of the glomerular basement membrane, but not the mesangium. So there is no mesangial matrix expansion. There is no mesangial hypercellularity could be seen in biopsy. The circulating antibodies IgG cross the glomerular capillary wall and bind to the podocyte antigen exposed on the food process, causing subepithelial immune deposit. IgG and complement, especially complement cascade from C5p to C9. IgG combined to the podocyte antigen, which we having two important antigens. The most one, and having a great role in the last guidelines in the diagnosis and management and prognosis for membranous nephropathy, is the phospholipase A2 receptor, PLA2R. Second one is thrombospodin type 1 domain containing 7A. There is multiple differences in histopathological features between the primary and secondary membranous nephropathy. Primary membranous nephropathy having IgG subclass IgG4 with absence of other immunoglobulins like IgA and IgM is usually absent. C1q is negative and having PLA2R antibody positive. But the secondary membranous nephropathy having IgG subclass IgG1 and IgG3 is more dominant, and other immunoglobulins like IgA and IgM present. C1q positive, especially in lupus nephritis, and PLA2R is negative. By electron microscope, primary membranous nephropathy having subepithelial deposit, but secondary membranous nephropathy is having subepithelial, mesangial, and subendothelial deposit. Clinical presentation of the patient having membranous nephropathy, it's coming with proteinuria, and about 80% of the patients having nephrotic syndrome at presentation. 20% of them having subnephrotic range proteinuria. Proteinuria usually is non-selective, and urine analysis has benign urinary sediment. No active urine sediment, no RBC cast could be seen with these patients. 70% of the patients are normotensive and having normal GFR at presentation. Acute renal failure is uncommon presentation with patient having membranous nephropathy, and it may be due to hypovolemia due to aggressive diuresis, could be due to acute interstitial nephritis due to medication and the diuretics used, and rarely due to complication of membranous nephropathy like acute renal vein thrombosis that leading to renal infarction. Renal disease risk category. We're having 3 categories according to the risk: low risk, medium risk, and high risk. Low risk having normal serum creatinine and proteinuria is less than 4 grams over 6 months of observation with conservative management. Medium risk group having normal or near normal GFR, proteinuria 4 to 8 grams over 6 months observation with conservative management. But the high risk group having deterioration of GFR, progressive decline in GFR, and proteinuria more than 8 grams for 3 or 6 months of observation despite using maximum conservative treatment including antiproteinuric medications. Other poor prognostic factors like heavy excretion of IgG and beta-2 microglobulin in the urine having poor prognostic factors, and in biopsy presence of glomerular focal sclerosis and tubulointerstitial disease having also bad prognostic factors. Finding in kidney biopsy for these patients. On light microscope, as we see in the left picture, there is thickening of glomerular basement membrane and presence of pathognomonic spikes of the basement membrane projecting from the outer surface of glomerular basement membrane. We observe here normal cellularity. And on the right, there is electron microscope picture for patient with membranous nephropathy showing subepithelial deposit. On the immunofluorescence, granular capillary loop staining for IgG and C3. And for idiopathic membranous nephropathy or primary membranous nephropathy, IgG4 subclass is the dominant in idiopathic membranous nephropathy. We have 4 stages. Stage 1 will be presence of electron dense deposit in the subepithelial zone between the podocytes and basement membrane. With progression of the disease, stage 2, basement membrane will make projections around the subepithelial deposit. With more progression in stage 3, there marked thickening of glomerular basement membrane and surrounding completely the deposit. With progression of the disease, it will be stage 4. The dense deposits will lose their electron density, causing irregular electron lucent zones. The prognosis of membranous nephropathy, going with third of the patients having spontaneous remissions, and the other third is progressed to end-stage kidney disease and may require dialysis. Other third will continue to having remission and relapse of proteinuria without progression to renal failure. In the recent guidelines for KDIGO guidelines published in June 2020, we having a great role for anti-PLA2R antibody in diagnosis, in assessment, the treatment, initiation and combination, and prognosis. So let's discuss in the next few slides the role of anti-PLA2R antibody. For patients with idiopathic membranous nephropathy, a kidney biopsy may not be required to confirm the diagnosis of membranous nephropathy. So we can make a diagnosis with non-invasive procedure like renal biopsy. So patient presented with nephrotic syndrome, we will do diagnostic evaluation for urinary indices, assessment GFR, ANA, assess the level C3 and C4, virology marker, hepatitis B, hepatitis C, HIV. We will assess serum anti-PLA2R antibody for negative ANA, negative virology, and only anti-PLA2R antibody positive. This is active primary membranous nephropathy. But if the patient having negative anti-PLA2R antibody, we're going for renal biopsy. Sometimes we can do biopsy stain for anti-PLA2R. If it's negative, this is secondary membranous nephropathy. If it's positive, this is inactive primary membranous nephropathy. But when to consider a kidney biopsy in PLA2R antibody positive patient? As we said, if the patient having negative anti-PLA2R antibody, we will going for renal biopsy. If the patient having positive test with normal kidney function, no need for kidney biopsy. But if the patient having positive test with considering immunosuppression, we're going for renal biopsy. If the patient having positive test with rapid unexplained deterioration of GFR or unusual clinical presentation, or having positive serological abnormality like ANA positive, we will going for renal biopsy. Any associated conditions should be excluded regardless the patient having PLA2R antibody positive or negative. So we will do some investigation like chest X-ray to rule out sarcoidosis. We will take a good drug history about non-steroidal penicillamine. We will do ANA test. We will take full history regarding systemic disease and physical examination, including joint and skin. We will do virology marker. We will do abdominal ultrasound, and we will screening for malignancy, especially for older patients. Like we will do PSA for male and mammography for female. Another important issue for using serum anti-PLA2R antibody test to guide treatment decision. So how can you use the antibody testing to guide the treatment decision? Patient primary membranous nephropathy with positive anti-PLA2R antibody, we will keeping conservative for 3 to 6 months and checking the level, the antibody level. If the level is disappear, this means that patient is going for remission, so no additional therapy needed. But if the patient showing that the titer is increasing or the proteinuria is deteriorated, this means persistence of the disease activity, and here we will consider starting immunosuppression. We have clinical correlations of circulating anti-PLA2R antibody. PLA2R antibody is present in 80% in patients with primary membranous nephropathy. It having 80% sensitivity and 100% specific for primary membranous nephropathy. The anti-PLA2R antibody can be present for many months before proteinuria appear. Patient with negative test can become positive later. High antibody levels before and after treatment correlate with proteinuria. So massive proteinuria correlate with high antibody level, and low proteinuria correlate with low antibody level. And even high antibody level correlate with response to therapy and after therapy and long-term outcome. Low antibody level means remission, and high antibody titer mean either relapse or resistance to treatment. Patients with higher antibody level require more prolonged immunosuppression to achieve remission compared with the other patient with low antibody level. Anti-PLA2R antibody level go down with remission and return high with relapse. For recipient patients going for renal transplant, elevation of anti-PLA2R antibody level at the time of presentation, unfortunately, this is prediction of recurrence of membranous nephropathy in transplanted kidney. What about the treatment of membranous nephropathy? There is general supportive treatment including antiproteinuric medications. We will give the patient the maximum tolerated dose from ACE or ARBs without side effect. We will give the patient statin, anticoagulation, diuretic to control the edema, salt restriction with adequate nutrition. Anticoagulation therapy in patients with membranous nephropathy depend on multiple factors, but it depends mainly on serum albumin. For patients with serum albumin more than 30 grams per liter, no therapy is needed. But patients with serum albumin level from 20 to 30, we will assess estimate arterial thromboembolic risk. If it's low risk, no medication is given. If it's high risk, we will give aspirin. For patient having serum albumin less than 20, and high risk for venous thromboembolic events, we will assess the bleeding risk. If the patient having serum albumin below 20 with high bleeding risk, we will give only aspirin. If low bleeding risk, we will give either warfarin or low molecular heparin plus aspirin. In the recent guidelines for KDIGO, they use clinical and laboratory criteria to assess the risk of progression of kidney function, and they divided it to 4 groups. Low risk, patient having normal GFR, proteinuria less than 3.5, albumin is 3 grams. And according to this classifications, they will decide the treatment. The second group is moderate risk, normal GFR, proteinuria between more than 4, but there is no reduction no reduction in proteinuria less than 50% over 6 months, despite control giving the patients conservative treatment with antiproteinuric medications, and PLA2 antibody level is less than 50, and urinary IgG excretion less than 250 milligram per day. High risk group, GFR start to be declined less than 60 with proteinuria more than 8 gram per day for 6 months, with PLA2R antibody level more than 150 and urinary excretion of IgG more than 250 milligram per day. Very high risk group, it's life-threatening nephrotic syndrome with rapid deterioration of the kidney function. According to this classification, we're going for giving the patients either immunosuppression or not. Immunosuppression therapy should be restricted to patients considered at risk for progressive kidney injury. Immunosuppressive therapy is not required in patients with membranous nephropathy and proteinuria less than 3.5 gram and normal GFR. So the low risk group, we will wait and see, give conservative treatment, follow proteinuria, follow anti-PLA2R antibody level at 3 and 6 months. For moderate risk, wait and see, and if there is no improvement of the proteinuria, we will either give rituximab or CNI. For high risk group, we will start treatment immediately, either rituximab or cyclophosphamide, or we can give combination CNI plus rituximab. Very high risk group, from the start we will give cyclophosphamide. The guidelines say that immunosuppression therapy is not required in patients with membranous nephropathy with normal GFR unless at least one risk factor for disease progression is present, or unless serious complications of the nephrotic syndrome like AKI, infections, thrombotic events have occurred. And for patients with membranous nephropathy and at least one risk factor for disease progression, the guidelines recommend using rituximab or cyclophosphamide plus steroids for 6 months, or CNI-based therapy, tacrolimus, for 6 months, and choice of therapy depend on the risk estimate. Some medication to be used for treatment of membranous nephropathy, cyclophosphamide can be given as cycler or continuous as Botticelli or modified Botticelli protocol. Rituximab, in the recent guidelines, it will shifted from just treatment for resistant cases to treatment of a choice and first-line treatment for membranous nephropathy. Rituximab can be given either 1 gram, 2 doses, 2 weeks apart, or can be given 375 milligram per meter square weekly for 4 doses. Tacrolimus and cyclosporin can be given with steroids for duration up to 1 month with checking of trough level regularly. Other new medication like beta cells and plasma cells targeted protocol can be used in idiopathic membranous nephropathy, like other anti-CD20 like ofatumumab, anti-beta lymphocyte stimulating antibody belimumab, plasma cell targeted protocol bortezomib. Rituximab used in membranous nephropathy before it was only in guidelines published 2012, it only preserved for resistant cases, but now the guidelines changed it to first line treatment. There is multiple trials. One of the most important of them is Mentor trial. It's comparing rituximab versus cyclosporin in idiopathic membranous nephropathy. It includes around 130 patients with idiopathic membranous nephropathy, and their follow-up was up to 24 months. It was designed to show that rituximab is non-inferior to cyclosporin in inducing remission of proteinuria and showing the adequate safety profile for rituximab. And as we see here, the result of the Mentor study, it's showing that rituximab is superior for cyclosporine in inducing remission with acceptable safety profile. Mentor study suggested that rituximab should be the recommended alternative agent for treatment of membranous nephropathy when alkylating agents are not suitable. Another important role for anti-BLA2R antibody is for monitoring the therapy. BLA2R antibody level at 3 and 6 months after treatment may be useful for evaluating treatment response in patients with membranous nephropathy and can be guided to adjustment to the therapy. So patient giving either rituximab, CNI, cyclophosphamide, we will do basal anti-BLA2R antibody level, and we will assess the antibody level after 3 months. For patients, anti-BLA2R level absent, no additional therapy. For patients receiving rituximab, for patients with cyclophosphamide will start withdrawal, and for patients receiving CNI we will continue. And after 6 months we will recheck the antibody level again. If it's absent, we will continue as protocol to withdraw the treatment. But patient having antibody level stable, no change at 3 months, for patient received rituximab, they will need extra dose. For patient receiving cyclophosphamide, we will continue on cyclophosphamide, and patient receiving CNI, we will continue. And we will check again the antibody level after 6 months. If it's moderately increased or slowly increasing, additional or combined therapy is needed. If the patient after 3 months having the antibody level is increased, if we started with rituximab, extra dose will be needed or additional combination with cyclophosphamide or CNI is needed. For patients started with CNI, cyclophosphamide or rituximab will be given as additional therapy, and we will check again the antibody level after 6 months. If it's still persistent or increasing the antibody level, we will deal with this case as resistant. Patient achieved remission and having later on initial relapse after the therapy. Treatment of the initial relapse after the therapy will depend on the initial treatment. So for patients receiving initial treatment with rituximab and having remissions, then later on having relapse, we will repeat rituximab dose. For patients start initial treatment with CNI, rituximab plus or minus CNI can be given for relapse. And for patients with initial treatment, cyclophosphamide can be given another course, or rituximab plus CNI can be given. What about the resistant cases for membranous nephropathy? It will depend on the initial treatment. For initial treatment, for patients who received rituximab as initial treatment and still there is resistant disease, for patients with stable GFR, we will add another dose of rituximab plus CNI. For patients with decreasing GFR, cyclophosphamide will be given. For patient resistant cases with treatment from the start CNI, if GFR is stable, we will add rituximab. If GFR is decreasing, we will add cyclophosphamide. For patients starting with cyclophosphamide, with GFR is stable and there is resistant to treatment, we will add rituximab. If the patient after the second evaluation of the treatment is still resistant, we will make combination rituximab, cyclophosphamide and CNI, and we will assess the response. If it's still resistant to this combination treatment, we'll need to consult expert center. Last slide, we'll speak about evaluation of the kidney transplant recipient with membranous nephropathy. For patient evaluation, having membranous nephropathy, either they known to be anti-BLA or BLA2R positive antibody, or the antibody level is unknown for them, we will check the BLA2R antibody level before transplantation. If it's still positive, this means that high risk of recurrence, more than 50%. If it's negative or positive and becoming negative, there is low to medium risk, around 10 to 30% for recurrence. We finished our topic today about membranous nephropathy. We speak about treatment. We speak about the new guidelines and the role of anti-BLA2R antibody in diagnosis, in management of the treatment and prognosis. Stay safe. Thank you very much.